Welcome to Module 1, titled Opioid Pharmacology, the Brain Reward Pathway, and Opioid Use Disorder. My name is Amy Wermeyer, and I will be the presenter for this module. Our learning objectives for this module are for the participant to be able to describe how opioids work in the brain and contribute to things like pain relief, cough suppression, respiratory depression, and euphoria, to define opioid use disorder, dependence, and withdrawal, and to recognize risk factors for the development of opioid use disorder. In order to talk about opioid use disorder, we first need to understand what are opioids. Well, they are a specific class of medications used to treat pain, and they're derived from the poppy plant, also known as Papaver somniferum. You may hear the terms opiate and opioid used interchangeably throughout this training and elsewhere. Technically, an opiate is specifically a natural compound derived straight from this poppy plant that you see pictured on this slide, whereas an opioid is either a natural, synthetic, or semi-synthetic chemical that interacts with the opioid receptors found in the brain and other organ systems.
This slide serves as a reminder of some of the most commonly used opioids, which is information you might already be very familiar with, but just wanted to make sure we're all on the same page. Opioids carry out their pharmacologic activity by binding at one or more of the various opioid receptors that can be found throughout the central nervous system and in other organ systems as well. We typically think of the actions at the mu receptor or the agonism of the mu receptor as a usual expected effect from an opioid. And you can see I've highlighted respiratory depression, euphoria, and physical dependence, as those are things we're going to talk in a little more detail about as we go through the rest of this module. But keep in mind that supraspinal and spinal analgesia, as well as sedation, also occur because of agonism of the opioid at the mu receptor. Some of the opioids will also have activities at one or both of the delta or kappa opioid receptors as well, and you can see the various functions associated with those receptor activities. And it's also important to note that our own endogenous opioids, like beta endorphin, also utilize these receptor systems to bring about our normal physiologic responses to pain and bring about a natural pain relief. Let's review how opioids can contribute to pain relief and cough suppression. If we look at the pictures on the right, you can see all the areas where pain is listed next to the image of the brain. So opioids attach to opioid receptors on nerve cells in the brain, the spinal cord, the gut, and other parts of the body. And when this happens, the opioids block pain messages sent from the body through the spinal cord to the brain. And that's obviously the reason why we typically want to use opioids, because they are able to effectively relieve pain. And if their only effect was to land at the opioid receptors in the brain and block pain, that would be great, and we wouldn't have this presentation or a need for this module. But as we've already alluded to, opioids don't only contribute to pain relief and cough suppression by binding at mu receptors. Unfortunately, they also contribute to respiratory depression. So this is a dose-dependent adverse effect of opioid therapy as a result of opioid binding to mu receptors in the medulla oblongata. The medulla oblongata is responsible for regulating our balance of carbon dioxide and oxygen and impacting our breathing rate as a result of the balance of those two things. So opioids decrease the sensitivity of the medulla oblongata to carbon dioxide and slow down the breathing rate. So not only do they reduce the ability of our brain to recognize that we're maybe reducing our oxygen content and our carbon dioxide content is rising, but they also make it so that the brain is then less able to respond by increasing its own breathing rate to compensate. And this is the underlying mechanism of death in an opioid overdose because of the brain's inability to regulate its own speed of breathing and its own recognition of lack of oxygen. Furthermore, opioids contribute to the experience of reward or euphoria. When an opioid lands at mu receptors in the ventral tegmental area or the nucleus accumbens, this causes a spurt of dopamine to be released into the brain. And when this happens, that's a powerful signal in the human brain that this was a positive experience and something that should be repeated, also known as a reward. And when a human or animal performs an action that satisfies a need or fulfills a desire, the neurotransmitter dopamine is released into the nucleus accumbens, and that produces pleasure. This serves as a signal that the action promotes survival or reproduction directly or indirectly. That system's called the reward pathway. When we do something that provides this reward, the brain records the experience, and we are likely to do it again. However, opioids sort of hijack this reward system and start to cause it to derail in some ways. There are some important things to know about the reward pathway. The first is that every human has one. It gets pinged with dopamine when we eat food we like cheese, when we engage in socially connecting activities, during sexual activity, or when you're drinking your favorite coffee, you get a little spurt of dopamine. The more the reward pathway gets used, the more lanes of the highway in the brain that it will build to support this traffic. The reward pathway is prepared, evolutionarily speaking, for the smallish amounts of dopamine it experiences in everyday life. However, it is not well prepared for the significantly larger amounts of dopamine that are released by things like drugs of abuse. It adapts to these repeated high amounts of dopamine, but it cannot resist them. The reward pathway also gets really cranky once it's used to receiving large amounts of dopamine. It can lose its capacity to feel smaller amounts of dopamine, so that regular rewards become not very pleasurable once it's gotten used to receiving larger amounts of dopamine, like in the instance of a repeated use of a drug of abuse. The reward pathway also makes a person feel very lousy when it is not getting high amounts of dopamine after becoming used to them. It is also finally very important to note that the reward pathway can heal. It can revert back to baseline when a drug of abuse is no longer being used, but this does take time to reverse the adaptations that occurred when there has been high use of the reward pathway in the past. And it's also important to note that if the sort of lanes in the reward pathway have been built up because of frequent or high use, it can be more easily rebuilt again if a stimulus is present. So what that means is that it remains susceptible to relapse even after someone has had healing and recovery from overuse of a substance that produces a lot of reward. Let's refresh on a few terms that relate to how opioids impact the reward system. The first is dependence. This is defined as physiologic change that occurs when using a substance. And withdrawal is defined as an acute, intense, typically physically and emotionally unpleasant reaction. And you can see the symptoms and some of the characteristics that are associated with opioid withdrawal listed on this slide. It's important to note that dependence and withdrawal are biologically occurring phenomena when an opioid is being used. They are the result of the brain's natural adaptation mechanisms. And we expect that these are going to occur for just about anybody who is using an opioid for longer than a 2-week period or so. And the occurrence of dependence and experience of withdrawal alone do not mean that a person has become addicted to an opioid or has developed an opioid use disorder or opioid misuse. They are expected biological adaptations of the brain as a result of the use of an opioid over time. In contrast, this slide depicts the information that is associated with opioid use disorder and the application of that diagnosis. And these criteria come right out of the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition. And in order for someone to be diagnosed with opioid use disorder, they need to have at least 2 of the listed 11 phenomena occurring within a 12-month period. Notice at the bottom that number 10 and number 11 are tolerance and withdrawal. Tolerance means needing more of a substance to get the same effect over what occurred at baseline. And withdrawal, we just talked about in the previous slide. Those alone, tolerance and withdrawal, are not enough to result in the diagnosis of opioid use disorder. At least one of the other characteristics, 1 through 9, must also be present. So take note of some of the things you see listed under the diagnostic criteria. These are important to have in mind as you think about what we're screening for when we're using the ONE program, and what we want our patients to be aware of, that they may be at risk of developing over time with use of an opioid, especially if they find themselves using it differently than the way it was prescribed to them. It's important to know that the etiology of substance use disorders is now widely accepted as a disease rather than as something that originates from moral flaws or willful choices. So we know now that individuals who suffer from the disease of substance use disorder, or in our case, opioid use disorder, do not choose to contract the disease any more than someone who suffers from heart disease or diabetes chooses to contract those illnesses. Sometimes those illnesses result from behavioral mechanisms, and the same can be true for substance use disorder. But once the disease process is in place, the willful choices may not have the ability to impact the disease progress, and the disease process begins and may continue regardless. Though individuals may choose to use a substance initially, biological changes in the motivation and reward systems in the brain caused by chronic use may actually perpetuate use due to cravings and the avoidance of withdrawal. Brain changes do persist over time in substance use disorders, and they confer vulnerability for disease progression and or relapse in the future, but this is very treatable and recovery is likely. Research over time has identified factors that increase someone's risk for the development of opioid misuse or opioid use disorder. These include age, with someone being currently less than 65 having an association of greater risk for the development of opioid misuse or opioid use disorder than those that are over the age of 65. And the age of first use of an opioid also can significantly impact the risk for the development of a use disorder in the future. Family and or personal history of substance use disorder also increases the risk for the development of subsequent opioid use disorder. The experience of chronic pain and having been diagnosed with a mental health disorder, especially that which is not well controlled, also increases the risk for the development of opioid misuse or opioid use disorder. Specifically, the diagnosis of major depression, psychosis, or PTSD, as well as the use of psychotropic medications, especially benzodiazepines, may confer increased risk for the development of opioid use disorder down the road. Research has also shown us that the more risk factors that someone has compounded together, the greater the odds are that they would develop opioid use disorder with the introduction of an opioid into their world. So you can see on the far right-hand side, the combination of all of those risk factors we talked about on the previous slide would confer an odds ratio of 56 times greater than someone who had none of those risk factors for the development of opioid use disorder.